This is a non-promotional podcast funded and developed by AbbVie for UK healthcare professionals only. The content of this podcast is correct at the time of recording, which is May 2026. If you are listening to this podcast through a podcast app, please note that any advertisements you may hear are not affiliated with this podcast or AbbVie in any way.
It is striking. You mentioned at the beginning of the podcast, Mark and I are friends, which is not entirely true.
Oh, okay.
Honestly, he did once dye my feet yellow.
I think that's pretty close then.
Yeah. We can look and see, is time to treatment actually important? Well, we can analyse that using the audit data, and it is. So if you get a DMARD on the day of your diagnosis, or you get it within 3 weeks of being referred, you're more likely, significantly so, to get into remission than if you wait more than 6 weeks or even 3 months.
It is easy to forget that when you see someone with rheumatoid arthritis, those first few months of treatment response really matter. Yeah. You need to measure and quantify disease response. It's not a checkbox exercise. It is a really crucial bit of care. So measure and keep measuring until you've got to an acceptable level of disease control.
Hello and welcome to Chat Room, a podcast where we sit down with expert rheumatology healthcare professionals to discuss topics that interest and matter to them the most in rheumatology, whether that be clinical challenges, patient quality of care, and the future of rheumatology. I'm your host, Ella Granger, and to launch the kickoff of Chat Room, we have two exceptional rheumatology consultants in the room with us today, Professor James Galloway and Dr. Mark Russell, who are actually also great friends, so it's so great to have you both in the room with us today, where we're going to be discussing all things remission. How do we define remission? How do we measure it? But we're also going to be talking about some challenging topics surrounding the stagnation of remission rates across England and Wales, and also how remission rates vary between different regions of the UK. I'm so excited to discuss this topic, and I think it's really important that the rheumatology community also starts talking about this more. But before we dive in, I'm really excited to introduce James and Mark. So James, why don't you start with introducing yourself?
Well, thank you for the invitation to be here. I am a rheumatologist. I am an epidemiologist as well, and work in a research group at King's College London. Do my clinical practice at King's College Hospital, so sort of South London, about a mile and a bit south of the river in central London. And I have a particular interest in rheumatoid arthritis and inflammatory arthritis, and also studying health outcomes and also national audit. We'll maybe come back to that later.
Thank you. And Mark, yourself?
Thanks very much. Nice to meet you all. I'm Mark Russell. I'm also a consultant, although a bit younger than James, and an epidemiologist and academic at King's College London. And so I spend a lot of time looking at big data, routinely collected data sets, but also the national audit. And lots of what we've focused on recently looks at changing remission rates, or perhaps the absence of change in remission rates. And look forward to discussing that today.
Amazing, thank you both. So I thought I'd start us off with what seems a simple question, but I think is actually quite complex in rheumatology, which is what is remission to both of you? What does it mean? How do you measure it? And what does it mean to your patients as well?
Mark, where do we start?
I mean, I think it's tempting as a rheumatologist, and when we talk about it from a data side of things, often the focus is on DAS28 remission or clinical remission, because that's what is drilled into us as clinicians. That's what we know from NICE guidelines as being the key thing, where we aim for remission often as a target, if not low disease activity. If we don't achieve that, we titrate, and we're titrating towards a DAS28 target usually, and we all know the DAS thresholds for escalating. But I accept that this is, we might get someone into remission at 3 months, or what we define as DAS28 remission. That doesn't mean necessarily that the patient feels as though they're in remission. We often see people where we're happy that the joints aren't swollen, but they still have lots of pain, or they have lots of fatigue, or they've stopped working. So I think we have to be careful thinking about what we say is remission and what a patient might think is remission.
I guess there's a thing, isn't it? The words really matter. And I think what the word means is very different to different people. Because one thing we have to acknowledge, if you rewind the clock 30 years and say, how did the average rheumatologist assess disease? The word remission wasn't considered. We talked about burnt out disease, or we talked about, activity in joints, but there wasn't really quantification in routine practice around the disease activity. And in the 90s, the birth of the disease activity score really changed the way we could quantify disease. And that was pivotal to trials. That allowed trials to have an endpoint that was accepted by regulators, by EMA, the FDA, having this sort of this quantifiable disease severity. And those created this concept that if your disease activity score was less than 2.6, we would say your disease is well controlled, and it got the name remission. Although I remember my old boss, David Scott, always said that remission to him was a sort of religious term, remission of sin or something. And you talk to patients, and they also, that, you know, what does remission mean? They say, well, it doesn't resonate, because you say I'm in remission, but I still feel tired. I still know I have the disease, even though I haven't got swollen joints. So I think it is a complex word, and it means different things to different people. To me, as an epidemiologist, it means successful treatment. I think that's the headline.
And remission, correct me if I'm wrong, in rheumatoid arthritis, the term exists, but in something like AXPAR, it's not commonly as used. Is it used at all in AXPAR?
I think it's less well defined. And I think if we think AXPAR and even PSA, psoriatic arthritis to an extent, it's catching up with rheumatoid arthritis. And, you know, what we saw, James said, 20, 30 years ago, we've seen that over the last 10 years or so. And so I will still use the term remission in clinic. But I think it's that, although we use disease scores like BASDAI, etc., in axial spondyloarthritis, it probably in everyday practice it is less well defined. And so there perhaps it is a bit more holistic. When I see someone, they're feeling good, they don't have early morning back stiffness, their pain's well controlled, they're working, they don't have fatigue, I might say you're doing really well, we're in remission. I might also record a disease activity score, and probably will do. But I think the fact that it is less clearly defined probably means that we look at it more holistically, maybe. But I think broadly speaking, we should be doing that across all diseases, not just looking at a disease score, looking across all factors, asking patients how they're doing, how's everything with work, looking not just beyond the disease activity score, basically.
Yeah, it's the big picture, right? So it's so great to hear both of your perspectives on remission, which leads me to your National Early Inflammatory Disease Audit, also known as the NEIA data. And what struck me from this audit, looking at remission rates across England and Wales, was that despite earlier referral to treatment times and improvement in that, and also, of course, the availability of advanced therapies for those early diagnosed RA patients, why remission rates have still been broadly stagnant since 2018. So I wondered if you guys could both speak about what's going on there, and also what made you get involved in this audit to begin with. Were you expecting the results that came out of it?
Perhaps you ask the last bit first, because you've been involved in the audit since. Really,
well, I should say just for clarity, this is not my audit. The audit is not. It is an Health Quality Improvement Partnership commissioned audit, which is one of many national audits. And I think one of the things I am really struck by is when you look at research, and I cut my teeth learning how to analyse the British Society of Rheumatology Biologics Register, and spent my PhD years studying differences in the rates of, for example, septic arthritis between different TNF inhibitors. And so taking a class of drug and delving in it and finding that there are some differences in the risks of certain outcomes. And they were statistically significant, and they were published, and it was a lot of effort that went into describing those results. But then I looked at the early audit data and started to realise that the differences we see between drug A and drug B are really quite small compared to the differences we see in clinical outcomes between hospital A and hospital B. Right. And that observation that service variation is enormous, there's this variability in the care we see, in the outcomes attributed to care we see, it's a very powerful thing to see. And it's modifiable, because the things that drive care quality are often very structural things, service resources and service pathway design. And so that was one of the things that really drove me to the audit, because I am aware that audit is often seen as not the most exciting thing. People often resent the effort required to add data to the audit. And so I sort of, when I got into it, I was sort of this, mixed feeling. On the one hand, this is not the most popular thing. It's not the most exciting epidemiology in terms of it's not going to lead to complex modelling or papers published in the BMJ from it. But actually, it is really powerful in terms of if we want to, as a community, influence the outcomes of as many people as possible with inflammatory arthritis, with rheumatoid arthritis, the audit is one of the most powerful levers for change, I believe. And so that was one of the things that got me into it. I have been involved. I'm a methodologist with the audit, so the BSR run the audit, and it is an enormous piece of machinery delivering this sort of national wealth. So England and Wales data collection system, which is recording longitudinally outpatient performance data for the NHS, which is quite unique. If you look at most of the health quality improvement partnership audits, they are snapshot audits, often on inpatient data sets, often where you can just automatically extract the data points. So it is a really complex audit and a massive testament to the BSR for delivering it. But yes, your other point you said is if you look at the audit data, and the audit publishes once a year, and you look at the treatment outcomes, remission, as it was referred to in the report, they have been static. Which, Mark, you spent a lot of time looking at that.
Yeah, I think it's when it was actually last year's report, but also the year before that, we saw there were some really positive signs in that, as you say, time from when you're referred to when you received your first DMARD, such as methotrexate, seemed to be improving, certainly at a national level. And yet this, how we define remission, I guess, is a DAS28 below 2.6. Had been pretty static back to 2018 at about a third of the population, or a third of the new patients with rheumatoid arthritis. And it was surprising in that we are doing better with time to treatment, and we know it's all drilled into us about this window of opportunity. You must start it quickly. So that raised a question, is it actually important how quickly you start it, number one? Number two, we've got a great quality improvement. There aren't many other QI programs like this anywhere in the world. We've got good drugs. We're very fortunate in the NHS that the price has been driven down a lot for biosimilars, earlier access with the moderate RA pathway, for example, and yet we haven't seen improvement. And so could that be seen as, was that seen as a failure? And I guess that was the one reason we want to look in detail. I think one thing to say, well, first is it the right choice? We talked about a bit before about DAS28 remission. The other thing is we're looking at this at 3 months. Now, it's quite hard to get someone with newly diagnosed rheumatoid into remission, i.e. DAS below 2.6, within 3 months. That may be heavily influenced by how much steroid you give a patient. Now, we do collect some data on steroid in the national audit. Most people seem to get some form of steroid, but we have no idea whether that was a 6 or an 8 week course or whether that was a single intramuscular depot. So that's one factor to think about. The other thing is we can look and see, is time to treatment actually important? Well, we can analyse that using the audit data, and it is. So if you get a DMARD on the day of your diagnosis, or you get it within 3 weeks of being referred, you're more likely, significantly so, to get into remission than if you wait more than 6 weeks or even 3 months. But I think the key thing, one of the things we've found is, and I'm sure this reflects in practice, it is not the only factor. There are many other factors that influence whether you get into clinical remission early. So if you've waited 12 months before you've been even referred to rheumatology since your symptoms started, you are significantly less likely to achieve remission, even if you then get your methotrexate on the day that you'll see a rheumatologist. Differences by demographic factors. Older adults, interestingly, more likely to achieve remission than younger adults. Women less likely than men, and some differences, quite striking differences between different ethnicities as well. So individuals of black ethnicity, for example, less likely to achieve remission than other ethnic groups as well. But of all the factors, and this might lead to what we discussed later, how bad your disease is, say in terms of DAS28 or seropositivity status, is by far and away the single factor that has most sort of influence in terms of whether you. So if you're seeing someone with a DAS of 6 at diagnosis who's seropositive, the odds of them getting into remission within 3 months are very low. And I think this links into how we look at that. How do we sort of stratify risk? But I think go back to what you said before, James. The key thing, we look at these sort of national headline statistics in the report. and we see remission is static. But I don't know if, James, you've looked a lot at this before, looking at the difference in remission between regions or even hospitals. I think that is the key difference that we see.
Yeah, so I think, I mean, we need, there's different pieces to this, because one piece of the puzzle is the structure of the services, and another piece of the puzzle is the tools we have and what we're measuring. And if you just take the piece of the puzzle around the services and the design of services, do you have an EIA pathway? Are you seeing people in the right clinics? That it varies not just by region, but by individual hospital. And you can have, in a single region, in a single ICB, you can have amazing performing hospitals and poor performing hospitals very close to each other. And when you look at that sort of map, that sort of patchwork quilt of performance, it's striking. And the thing is, it's not the same hospitals in the good and the bad books each year. So it's almost like, you improve something in one place and it gets worse somewhere else. And all sorts of things drive this that we know. If you have a service that is strained and then someone retires, be that a doctor, a nurse, or a pharmacist leaves on parental leave or something, and the system gets more strained, then people take sick leave, and then you compound it with resident doctor strikes, service pressures in other directions. It's not a surprise that the quality of care we deliver in any given service goes up and down, and particularly the smaller services where they're more vulnerable to these sorts of issues. So there's no surprise, and I think in current times we're aware the NHS has got challenges that it is working to address, and we are swimming sort of up river to try and address these. And every time I look at the audit data, it's sometimes tempting to say, oh look, this hospital's getting low performance, we've got to tell them off. But that's absolutely not what we need to do, because where you see places where there's weaker performance, that's a sign they need support, and they need not to be told off, but to be helped up. And that's a challenging thing, because I think when you look at the audit data, it often does give the sense we're being monitored, Big Brother scrutinised, and we're going to get told off. And I think it's a challenge there. But so that's part of it. Is I think the audit, you look at a single number, and you're right, and that hides in there centres that do amazingly well and are getting 70% remission rate at 3 months, which I think suggests it is possible, and other units which are 10%, and so I think.
So would you say that it's sounding like it's leaning more towards a capacity issue and kind of what the services are resourced with, or would you say in some cases where a patient's put on methotrexate first line, are they being escalated to a biologic DMARD quick enough? Is there a delay to that, and does that come into it at all?
Yeah, so I think they're different pieces of the puzzle, and I'm cautious to say one is more important than another, because I think there is definitely going to be different pressures in different parts of the service. But if you take the service bit out of the puzzle and just say, best care, what are we doing? Then I think you are faced with the question, what does brilliant care look like? If I was to be diagnosed with rheumatoid arthritis this week, what would be the care I would want? And it's really interesting, because I remember an audience of rheumatologists being asked, you've just been diagnosed with rheumatoid arthritis, what do you want as your first line drug? Do you want a DMARD or a biologic? And they all said biologic. And this was over 20 years ago. Right. This was like, we knew, the writing was on the wall, that these drugs, the first time you as a rheumatologist you ever prescribe a TNF inhibitor, for example, it's the first class of drug I saw used as a biologic. Yeah. And it was such an astonishing response compared to methotrexate. And methotrexate used to be called a SARD, not a DMARD. It was a slow-acting anti-rheumatic drug. We sort of rebranded them, but they are. We counsel patients, don't expect to see a dramatic response quickly. Expect 12 weeks before we're seeing meaningful change. And why are we waiting 12 weeks for a response when we've got drugs that we see dramatic responses in 2 weeks? And I think that's an interesting question, because would we do better if we were to front-load treatment with our best options? Yeah. I think, Mark, you make a good point that you could make a strong case that if you see people quickly through primary care, there are some people who will get into remission quite easily, those with low disease activity when they present because they've been referred very quickly. So you could stratify where you were to front load.
And I think it's interesting, if you look at some of, these are not new trials, but if you look at some of the original early TNF trials and early biologic trials, and then also the comparator trials where you had sort of either early DMARD combined with steroid, irrespective, people did very well. And the Nord Star study, Scandinavia, showed that whether or not you received a biologic with methotrexate or combination DMARD with steroid, the remission rates DAS28 remission rates were towards 60 or 70% within 3 months. So it's almost, this is what is possible. The tricky thing is that there were multiple visits, multiple steroid injections, titrations within a short space of time. And the question is, how deliverable is that? So I agree that certainly stratifying would be important. If you see someone with really bad disease, we know from the audit data and many other studies, they are unlikely to get into early remission with standard therapy. Can we deliver monthly treat to target? At present, it is very difficult. It's possible in some units, but capacity is challenging. And I think looking outside there's also the question, James, as well, of how much variation there is between individual clinicians. We look at hospital level and we see this huge variation, but how much of that is due to system factors, hospital-related pathways, and how much is due to an individual willingness to escalate very sort of rapidly. So that's the other thing to look at. And I'm sure there is variation. There have been other studies in the US and Canada that have shown often how aggressively an individual escalate treatment has a big impact on outcomes. So that's certainly another thing. And it's harder to answer that, I think.
It is interesting when you look at the evidence, though, around upfront early intervention with targeted therapies. It is striking. You mentioned at the beginning of the podcast, Mark and I are friends, which is not entirely true.
Oh, okay.
Honestly, he did once dye my feet yellow.
I think that's pretty close then.
So on a morning, Mark and I will often exchange messages on the way to work, and quite recently you shared with me the North Star data. You're just showing the graph, just showing this is what's possible. And 60-70% people in remission, early treatment pathways. And it was actually, I think, one thing that struck me is not just the early response, but the long-term implications of early response. So Paul Emery's Leeds cohort, where they looked at, it wasn't how many people can get into remission early, but looked at what happens down the line. So how many people, they've got a 10-year follow-up on a early treated cohort where they had targeted therapy up front, and they see the number of people who get what we call difficult to treat RA, which is a term we use to describe people who have failed or cycled through multiple targeted therapies. That number was manyfold higher in the people who didn't have early targeted therapy, suggesting that early treatment, it's not just about whether you get an early response, but it's also about your trajectory for the rest of your disease may be influenced. And that these are the sorts of questions that I think are really interesting about if we've got an availability of tools, and the availability of the tools now is changing. So we're seeing changes in how the NHS is sort of commissioning pathways are working, and I think it makes us say, well, we should be looking at how we use the tools available to us to get the best outcomes.
Yeah. And so just bringing it back a bit to the region discrepancy, you've got hospitals like Leicester who they doubled their remission rates with under 18 months. Are they doing more of what you're talking about? Are they monitoring their patients more? Are they escalating to advanced therapy quicker or switching mode of action quicker? All of this. Could you speak a bit more about that?
Yeah, I thought it was, that's why I really like that case study, because sometimes you look at the national picture and you look at your service and you think, well, we haven't got the resource to have extra staff, and how can we possibly improve? And I think that was a really nice case study, because it wasn't that they had to hire many additional staff to do that. I think they'd been flagged as an outlier for underperformance relative to the quality standards a few years ago. And it was some of the key things, and we'll come back to later on about the quality improvement things that you can do within your existing sort of resource envelope. So looking at their triage pathways, making sure that those with EIA, particularly those with bad disease, are seen in an appropriate clinic. Make sure you've got dedicated early inflammatory arthritis clinics. Looking at sort of a flexibility, that idea that you need to have appointment availability for people who have really bad disease so that you can see them on that monthly treat to target type approach. And so I thought it was really good in that it is not that you need to necessarily have many additional staff, or even that you have to change your pathways. I mean, I'm sure that, again, there'll be lots of individual variation in how quickly you are titrating, how quickly you're using biologics. But I think looking at those sort of more basic things early on, I mean, we saw that they are almost every patient in their unit seems to get a DMARD within the recommended time frame. Their remission rates are about as good as you get in the national audit, so towards 50%. It's really impressive. And I think that's, again, it's not about telling off units, about how can you use that to improve.
Yeah, exactly.
Yeah, one thing, for example, is, do you give methotrexate on the day you diagnose someone? So Liz Price is head of the audit, and she a former BSR president, and she has been instrumental in sort of huge things in the audit in the last couple of years, driving one change, for example, the encouragement of starting methotrexate on the day of diagnosis. Right. And it's funny because I've been involved in the audit for a long time, and it was her saying, just look at this one factor. Because I think we have almost made a little bit of an industry around counselling people about starting methotrexate, in part based upon legacy concerns around the safety of the treatment. Most of those concerns have been diminishing with better understanding of the drug. So, for example, we used to be concerned it could cause lung fibrosis. We don't think that is the case anymore. We used to recommend very intensive monitoring, and the latest monitoring guidelines, the latest DMARD monitoring guidelines, have now said you can reduce monitoring. In fact, people who are on stable treatment without comorbidities, a blood test even twice a year is probably sufficient. So there's been a substantial reduction in our concerns around toxicity from the drug, and yet we still have this quite extensive counselling process, which is not in keeping with most other disease areas. If you go and see a patient with, and you could list the specialty areas in neurology or respiratory medicine or gastroenterology, they don't have akin counselling for drugs that are similar risk-benefit thresholds. Why are we still doing it in rheumatology? And actually, I think it's a really good point that Liz has made, is why don't you just give the prescription on the same day? It's not that you don't need the nurse specialist appointments, but those appointments should be about disease education and self-management, rather than this is how you take methotrexate, which historically maybe puts people off taking it if you spend a lot of time talking about the side effects.
Yeah. Do you think the reason that there's less toxicity or worry with it is because actually they're not staying on it for as long anymore, and they're being moved to an advanced therapy now?
It's a good idea, good point. Although, well, if I'm truly honest, I was never that sure that methotrexate was causing lots of toxicity in the past. We did have an issue, I think, with if you look at the early use of methotrexate, we were using it in people with very long-standing established rheumatoid who had much more comorbidity than what we see now. And so I think the population we're treating has changed. It's interesting. If you said, how do I compare toxicity profiles of methotrexate versus biologic TNF, I think things like liver enzyme abnormalities or blood cap abnormalities probably are more common with methotrexate than some of those drugs. And I think our threshold for going to targeted therapies is much lower now than it was 20 years ago, 10 years ago.
But some of that's we get familiar over time. When TNF inhibitors were introduced 20, 25 years ago, meta-analyses at the time suggest there might be an increased risk of cancer. In part contributed not just cost, but to why your threshold was quite high to go onto it. You didn't want to give it to someone with milder disease who might get there with a conventional drug if you had this other class of drugs that might cause cancer, and we didn't know. And then we've now got 25 years of safety data. We've got huge registry studies, real-world studies, some of which done by you, James, that show that there doesn't appear to be an increased risk of cancer with, for example, TNF inhibitors or other. And in fact, maybe some signals actually that might reduce it because, again, these contextual factors, how active your disease is probably the biggest driver of whether or not you get a serious infection, whether or not you develop a malignancy such as lymphoma that can be associated with rheumatoid. Not just in rheumatoid, you look at other diseases, it's true also of inflammatory bowel disease as well. How active your disease is often one of the key factors that determines whether or not you get a cancer associated with inflammatory bowel disease, such as colorectal cancer. And so I think there is this sort of familiarity over time. We get more comfortable, we see more data. And so that's probably a key factor where we sort of our threshold to commence something might lower over time.
Okay, thank you both. So my next question is something I'm actually really keen to hear both your answers on, and that's in those regions with slightly lower remission rates, are you going into those hospitals to have those discussions with department heads, clinicians? If so, how do they go? Because I can imagine it's quite confronting for them to be told that maybe their remission rates aren't doing as well as you'd hope. Do they challenge the data? Are they very hesitant to provide data to you for the audit? And yeah, just interested to hear.
James?
Well, it's an interesting question. So when the audit first started, I went to visit many of the hospital trusts. We did interviews we identified the 10 of the worst performing trusts and 10 of the best performing trusts, and we went out to interview them to try and understand what it was that was driving that variability and what is it that makes a successful unit and what makes a less successful unit. Without going to at the moment when trusts are not performing well, the BSR has a whole infrastructure. Liz Price phones them, the BSR team centrally contact them. So as methodologists, we're not involved in that person bit, but they're often on the email trails. But one thing I'd say, I think if you are a clinical lead of a service and your service is not performing well, it's very hard not to take it personally when that data set is put in front of you. And it feels, I think it feels, and having previously, in years, the hospital I work in we both work in, has been in outlier status before. And it does feel like a bad reflection on what you're doing. So that, there's no doubt about that. However, it is also a very powerful lever for change. And if you have a huge hospital, rheumatology is sometimes a poor player in the stakes, especially as we don't have inpatient beds, and that's where a lot of the cost pressures in hospital services and acute medicine drive from. And so as an outpatient-based specialty, it can be hard sometimes to be heard as a voice in the sort of the senior exec in the hospital. If you are on the radar for national audit that there is an issue, that can help you move a lever and say, actually, we need, and maybe it's clinic space, maybe it's staff, maybe it's administrative support, whatever it is. But the audit is a powerful lever. And so although the initial approach is often difficult, and I think, I say difficult, I think in rheumatology we're probably a friendlier specialty in some specialties. But over time, and Leicester's a great example where it actually came with really positive outputs to turn things around.
I think it's not putting morality on the data point and actually just taking the data point and then using that as feedback to improve your service.
I think one of the sort of helpful shifts is that there's been this move away from it just being this static annual report to now having dashboards, so that you don't just need to wait until your next year and think, am I going to be an outlier? Okay. You can do quality improvement earlier on. So it's, there's so many, as trainees, it wasn't that long ago that I was a trainee where you have to do quality improvement projects. And sometimes the pain of doing that can be collecting data. Whereas now we have dashboards that publicly available. You can look at your trust, you can look at your neighbouring 3 trusts, you look at national standards. For example, did you get a DMARD early? Did you get into clinical remission early? And you can do many of the things that we talked about that say Leicester are done well and that other trusts are doing well. You can sit down with your department. It's an amazing way of doing a good quality improvement project that really delivers change. And there's so much encouragement. We're always looking for examples in the audit and through BSR of units that are doing things to try and improve care. And it doesn't have to be the senior consultant in the department. Often it's trainees who take an interest in it and use the data that we now have available. So I think that will, if not already, make a big difference to sort of improving care, and that in turn shifts up the national average as well.
Absolutely. I mean, I didn't know that dashboard existed. That's amazing. Can other hospitals see how other hospitals do? Wow. Okay. That's brilliant. Go ahead, James.
So one thing, the bit about getting trainees doing stuff, it is really interesting, the sort of shared learning that happens through the audit. So the BSR publish a whole raft of tools for how you can help change things. But it's so interesting when you see how individuals, it is often the residents, the people who are, just rotating through for 12 months can look at something and say, what about doing this? And that is a really interesting bit about seeing how you get this sort of organic sort of sharing of how you do things. And you realise NHS systems, although it is one NHS, they are enormously different in how services are designed and run around the country.
Amazing. Thank you both. I think I've just got one last question for you. Being moonshot thinking, if we were to double our remission rates in the next few years, what do you think, what would that look like? How would that need to happen?
I think, how would we achieve that? Well, if we can, the devil's advocate, if you were to be able to go by the book, follow existing NICE guidance, monthly treat to target, and get early escalation to biologics by 3 months of people, it is, we've seen from previous trials, it is possible in theory to get there. Do I think that's achievable in the NHS currently? I think it's challenging. And I think if we're looking at a national statistic, that is not going to be possible because the majority of units won't be able to do that. I think I think many of us are thinking that the cost of biosimilar TNF and biosimilars generally is really shifted it towards should we be using biologics earlier on, and I think that may be something that gets looked at. It's interesting, of course, that the EULAR guidelines recently updated still advocate methotrexate as part of the first initial treatment strategy. If you don't do well enough on that, then you would go to a biologic, so more sort of aggressive than we are with existing NICE guidance in the UK. Interestingly, they still didn't necessarily recommend first-line biologic. And if you look down, I found it very interesting looking down into the detail of that, where rightly they cited studies such as Nordstar that show you if you give steroid plus conventional DMARD, you can get good remission rates. But I think the reality is delivering that in the current state is very hard. The other thing, of course, again, is if you look at the longer-term outcomes from studies such as Nordstar, or indeed you do a meta-analysis of all those early treatment studies, there was clear evidence of benefit with having earlier aggressive treatment, earlier involvement of biologics. And so I suspect that as cost reduces, that's where we are heading. And I do think that would make it more achievable.
Yeah. Thank you. And James, anything to add?
Yeah, I think 10 years, see someone, blood test, seropositive rheumatoid, start them on a biosimilar TNF.
Yeah.
And methotrexate, yes, low dose, 10 milligrams, reducing immunogenicity, and don't need monthly treatment escalation because there's no dose escalation around TNFs, and we don't use steroids. Those are bygone. We laugh at people who used to use steroids a decade ago. And then it's your decisions about how soon would you switch. Yeah. And so there's no need to see people monthly in the NHS because you just start them on a biologic and say, we'll see you in 3 months. Yeah. And you have probably an AI sort of person who will talk to you and see how you're doing, which is all automated, perhaps centrally administered. So you just get in and you talk to your, I don't know, whatever commercially available language model is out there to say, hi, how are you feeling today? How are you finding your new injections are working? And so my suspicion is that we are going to use AI to make our services more efficient. We will probably see people less with drugs that work better.
Okay. So we've talked about so much today. One key thing that you want our listeners to take away from all of what we've discussed, and also maybe your audit as well. So you're the audit. I keep referring to it.
Yeah, it's not our audit. It is the audit. Return your data, obviously, for the audit. I think all of us in our care, treat to target is such a fundamental thing that it is really important you define whatever you call it, remission or treatment response. I think it is easy to forget that when you see someone with rheumatoid arthritis, those first few months of treatment response really matter. Yeah. You need to measure and quantify disease response. It's not a checkbox exercise. It is a really crucial bit of care. So measure and keep measuring until you've got to an acceptable level of disease control.
Great, thank Thank you. Mark, anything?
And I think, just linking back to before, I think it is, as you mentioned, it is tempting to see the audit as it's a pain to fill in the data, or it is only there to highlight underperformers. I think there should be that shift towards it is a good thing. It's a fantastic audit, and the date there are no other comparable audits that I'm aware of with such detailed data from those right from the point of sort of initial referral and diagnosis, and use those tools out there, those dashboards, see them as an opportunity to really improve care. And this doesn't mean massive quality improvement projects. It could be look at the 3 things that we could do to improve remission rates or improve patient-reported outcome measures. For example, DMARD on the day of diagnosis, looking at triage pathways. And so I think see it as an opportunity. That would be my main thing, and that's why the data's out there.
Yeah. It's such a powerful tool for conversation starters and asking those questions. Thank you both so much for joining the podcast. I'm really excited for our next episode on quality improvement, and then we also have another with you on managing risk in rheumatology, that benefit risk dilemma that we have. So thank you, and speak soon.
Thank you very much.
Thank you.
Thanks for tuning in on this episode of the Chat Room podcast. If you enjoyed it, you can find us on Spotify and on YouTube, so please make sure to give us a follow or subscribe. See you next time.